aortic regurgitation, general overview, definition and etiology of aortic regurgitation, classification, pathophysiology mechanisms, clinical presentation of the patient, diagnosis and treatment approach. So first of all, let's start with definition. So aortic regurgitation is the incomplete closure of aortic valve leading to the reflux of blood from the aorta into the left ventricle during diastole. It can be either acute or chronic, and it may be caused either by a primary valvular defect or secondary due to abnormality of the aorta. So for acute aortic regurgitation, most commonly it's caused by infective endocarditis. This can be caused by aortic dissection as well, some chest trauma, or iatrogenic complications after medical treatment or procedure, like percutaneous aortic balloon dilation or transcatheter aortic valve replacement. For chronic aortic regurgitation, it develops over time. It can be either due to a primary valvular defect, like congenital bicuspid aortic valve, calcific aortic valve disease, or rheumatic heart disease, or it can be due to aortic dilatation, like thoracic aortic aneurysm, aortitis of any etiology, some connective tissue disorders, or chronic hypertension. So, general classification of aortic regurgitation, we have the American Heart Association staging system. It's based on symptoms and echocardiographic criteria. So we have stage A, which is at risk of aortic regurgitation, stage B, progressive aortic regurgitation, and here it includes mild and moderate. Stage C, we have C1 and C2. Stage C1, asymptomatic severe aortic regurgitation with the left ventricular ejection fraction more than 55%. And stage C2, asymptomatic severe aortic regurgitation, but here the ejection fraction is less than 55%, or there will be left ventricular dilation more than 50 millimeter in diameter. And we have stage T, which is symptomatic severe aortic regurgitation. So coming into some pathophysiology mechanisms, so I will talk first about general what happens during aortic regurgitation, and after that what happens in acute and chronic. So in general, the regurgitation of blood from the aorta into the left ventricle, it leads to two things: increased systolic blood pressure, because the left ventricle will receive blood from the left atrium and regurgitant aorta, which will lead to increasing in the preload. And other thing that happens is decreased diastolic pressure, which is due to the rapid return of blood into the left ventricle due to this incompetent aorta or aortic valve. There will be also, like in physical examination, to mention that on physical examination we will have a water hammer pulse, which is mainly a widened pulse pressure. We can hear it like in the radial artery or in the carotids, which is referred to as Corrigan's pulse in the carotids. Now, in the acute aortic regurgitation, because the left ventricle cannot dilate sufficiently in response to the regurgitant blood, the left ventricular and diastolic pressure will increase rapidly as well, and the pressure will transmit backwards into the pulmonary circulation, and it leads eventually to pulmonary edema, and the patient will have symptoms of dyspnea. And this decrease in the cardiac output, if it's severe enough, it will lead to cardiogenic shock and myocardial ischemia as a complication. While for chronic aortic regurgitation, because it develops progressively, there will be a compensated increase in systolic volume, which can maintain actually an adequate cardiac output despite the regurgitation, which basically in other terms is compensated heart failure, and over time there will be increase in the left ventricular and diastolic volume, and eventually there will be a remodeling of the left ventricle by left ventricular enlargement and eccentric hypertrophy of the myocardium, and there will be dysfunction in the systolic uh, left ventricle in the systolic function, which will decrease eventually the ejection fraction and leading to decompensated heart failure with time. Now moving into the clinical presentation of the patients. So usually in acute aortic regurgitation, there will be a sudden and severe dyspnea and rapid cardiac decompensation secondary to heart failure. In this case, it will be acute pulmonary edema, as I explained right now, and symptoms related to underlying pathology, for example, fever due to endocarditis or chest pain due to aortic dissection. Usually on auscultation, there will be a soft and early diastolic murmur, which is short. While in chronic aortic regurgitation, usually the patients are asymptomatic at first, and with time, with the progression of the heart failure, there will be symptoms like palpitations, fatigability, and left-sided heart failure symptoms. On auscultation, we may find high-pitched decrescendo, early diastolic murmur, and S3 sound as a sign of volume overload. Now, coming into the diagnosis, the key or the primary diagnosis that we use in clinical practice is transthoracic echocardiography, and it's actually useful also for the assessment of the severity of the aortic regurgitation, and it can give us also an idea about the cause. For example, we can see if there is abnormal function or structure of the aortic valve, or for example within the aorta, like dilated aorta, or we can see also the presence of aortic valve leaflets abnormality, like bicuspid aortic valve or mitral valve leaflets can also be given a shivering of these leaflets, like general findings. In acute aortic regurgitation, usually there will be increase in the end-diastolic left ventricular pressure, and there will be early mitral valve closing with a rapid equilibration of aortic and left ventricular pressure. While in chronic aortic regurgitation, usually we will see increased in the left ventricular size and volume. We can use also blood cultures if we suspect endocarditis as diagnostic mechanism, NT-proBNP level to check for heart failure. ECTA is preferred if aortic dissection is suspected. ECG, of course, is one of the primary diagnostic methods that we use. We can notice some signs of left ventricular hypertrophy in chronic aortic regurgitation on some signs of ischemia. We can use also chest X-ray for detection of pulmonary edema. And also, like if we see, for example, that the transthoracic echocardiography findings are not conclusive, or if there is a difference between the presentation, the clinical presentation, and the symptoms of the patient and the findings on transthoracic echocardiography, we can use transesophageal echocardiography or cardiac catheterization or cardiac MR to confirm the diagnosis. For example, also cardiac catheterization are used to detect the intracardiac chamber pressures. So we can use these methods as well. Now coming into the treatment. So for the treatment for acute aortic regurgitation, of course, if it's severe acute aortic regurgitation, it will require surgical treatment as soon as possible. We have to treat also complications like pulmonary edema, treating the cause as well, like aortic dissection and endocarditis. For acute aortic regurgitation, as I said, it can be complicated by cardiogenic shock. So we have to manage it if it's this the case. We have to give constrictors or dilators. We have to decrease the afterload by vasodilators like nitroprusside, for example, and beta blockers can be indicated in aortic dissection, but usually are avoided in other causes of acute aortic regurgitation because they will decrease the cardiac output, and eventually it will prolong the diastolic phase, and eventually the regurgitation just will be increased. So it will lead to worsening of the case of the patient. So be careful with that. Now coming into the chronic aortic regurgitation, also we can use surgery for symptomatic and severe aortic regurgitation. Usually surgery is indicated in either symptomatic chronic severe aortic regurgitation or also asymptomatic chronic severe aortic regurgitation, but with reduced ejection fraction less than 55%, or if the left ventricular end systolic volume is more than 50 millimeters. Usually for surgery, aortic valve replacements can be indicated, and here we can use either mechanical or bioprosthetic valves. Depending on each case of the patient and also the preferences, this will be a shared decision, and it depends on each patient's case. Diode procedure or aortic rotary reconstruction if the aortic regurgitation is caused by aortic dilatation with a healthy aortic valve. Uh, for medical treatments, coming into the chronic aortic regurgitation, we have to treat heart failure using the standard heart failure treatments with beta blockers, uh, ACE inhibitors or ARBs, Entresto. Uh, we can use also MRAs, so or they and also diuretics. So we have to give treatments depending on each patient's case. Also, if the patient has hypertension, we have to treat it. Also, if the patient, for example, has higher risk, we can give a prophylactic antibiotics if there is high risk of developing endocarditis, for example, and continuous monitoring of the case of the patient to check the severity of the aortic regurgitation. And that's all. I hope it was useful. Thank you.